Dear student, the topic of this video is the thyroid gland. Learning objective. At the end of the session, the student will be able to describe the structure of the thyroid gland, how it relates to its function, define the chemical nature of the thyroid hormones and how they are synthesized, understand the critical role of iodine in the thyroid gland and how its transport is controlled, describe the role of protein binding in the transport of thyroid hormones and peripheral metabolism. Identify the role of hypothalamus and pituitary in regulating thyroid function. Define the effects of thyroid hormones in homeostasis and development. Understand the basis of conditions where thyroid function is abnormal and how they can be cleared. Thyroid is a butterfly-shaped gland that straddles the trachea in front of the neck. So this is the trachea, we can see. This is trachea. So in front of the trachea we have, so this is the trachea, in front of trachea we have this thyroid gland in front of the neck. It develops from an evagination of the floor of the pharynx. So this is the floor of the pharynx, we can say this is the floor of the pharynx. From that there is an evagination that forms ultimately the thyroid gland. A thyroglossal duct marks the path of the thyroid from the tongue to the neck. So this is the foramen cecum of the tongue. So from this is the pathway through which the thyroid gland moves from the tongue up to the front of the neck, and the thyroglossal duct, it shows this pathway. And sometimes this thyroglossal duct, it persists in adults. Thyroid gland has two lobes, right lobe and the left lobe. They are connected by a thyroid isthmus. So they are connected by thyroid isthmus, and sometimes there is a pyramidal lobe arising from the isthmus in front of the larynx. So this is a pyramidal lobe. So this part is a pyramidal lobe. Sometimes it arises from the isthmus. The gland is well vascularized. Now the portion of the thyroid that is concerned with the production of thyroid hormone is known as the thyroid follicle. So we can see the picture of the thyroid follicle here. These are the spherical thyroid follicles. Okay. Now these thyroid follicles, each spherical follicle, they are lined by a single layer of polarized epithelial cells, and it is filled with pink staining proteinaceous material called colloid. Colloid consists predominantly of the glycoprotein thyroglobulin. Now when this gland is active, it will show some different pattern. When it is inactive, it will show some different pattern. So when the gland it is inactive, you can see here the follicles, the colloid is abundant, and the follicles, so this colloid is abundant, follicles are large, and they are lined by flat cells. Whereas when the gland becomes active, the follicles become small, the colloid it is also it is less in amount, and you can see the cells. These cells are not flat here. These cells, now the follicles, they are lined by the cuboid or columnar cells. And most importantly, where the colloid is being actively reabsorbed into the thyrocytes, that areas which are known as the reabsorption lacunae, these reabsorption lacunae are clearly visible within these active follicles. Now microvilli project into the colloid from the apex of the thyroid cells and canalically extend into them. And there will be increased number of endoplasmic reticulum. So in the active gland, increased number of endoplasmic reticulum, and we can see so many secretory granules. So these are the secretory granules containing the thyroglobulin molecules, and these secretory granules will ultimately enter into the thyroid cell. Now the individual thyroid cell, you can see it is a basal lamina of this individual thyroid cell. They rest upon this capillary network, and these capillaries are highly fenestrated like those of the other endocrine glands. Now all the hormones, as we have seen in my previous videos, all hormones should be discussed under 7 headings. What are those? Chemistry of the hormone, biosynthesis, what is the metabolism of that hormone, secretion of that hormone, functions or actions, mechanism of action, and hyper and hyposecretion. So similarly, thyroid hormone, we will also describe it under these 7 headings. First come to the chemistry. The primary hormone secreted by the thyroid, it is the thyroxine. This is a T4. And along with it, there will be secretion of less amount of T3 and reverse T3. So all of them, they are iodinated amino acid. We can see in case of thyroxine or T4, 3, 5, 3 prime and 5 prime, in this position the iodine is located, and that's why it is the tetraiodo L-thyrronine. In case of T3, position of iodine is 3, 5, 3 prime, so it is the triiodo L-thyrronine. Whereas in case of reverse T3, position of iodine is 3, 3 prime and 5 prime. So we can see that what are the differences between this T3 and T4. T3 is around 300 times more active than T4. But 80 to 90% of the hormone that is secreted by thyroid, that is T4. T4 is the inactive thyroid hormone, but it is maximally secreted from the thyroid gland. And most of this T4 will be converted to the active form of T3 by some peripheral mechanism of conversion. And T3, it is seen that only 0.3% it is unbound and free for use for body, whereas in case of T4 only 0.03% is unbound and free for use in the body. Now what are the steps of synthesis of thyroid hormone? There are 5 basic steps. First step is the iodide trapping, followed by the oxidation of iodine ion. Then the third step is organification of thyroglobulin, that is incorporation of iodine into the thyroglobulin. And the fourth step is the coupling of iodotyrosine residues, and fifth step is the release of T3 and T4 into the blood. Now we are going to each these steps one by one. Before going to that, we must know about the iodine homeostasis. Iodine is an essential raw material for thyroid hormone synthesis. Dietary iodine is absorbed by the intestine and enters the circulation. The minimum daily iodine intake that will maintain normal thyroid function, it is 150 microgram in adults, which is the minimum daily iodine. Now in most developed countries, supplementation of table salt means, so in most of the countries now table salt is supplemented with iodine. If it is there and people are using that, that means average dietary intake, it becomes 500 microgram per day approximately. So this 500 microgram, it is incorporated in the diet and it will enter in the body. Out of this 500 microgram, we can see 120 microgram will be taken up by thyroid gland. So in the extracellular fluid, the remaining amount, it is around 380 microgram. So out of this 120 microgram, you can say that thyroid gland will utilize 80 microgram to synthesize the T3 and T4, and remaining for 40 microgram will be released again. So 500 minus 120, that is a 380 plus 40, that is 420 microgram. Now it is present into the extracellular fluid. Now these 80 microgram of thyroid T3 and T4, they will be metabolized in the liver and other tissues, and out of it 60 microgram it will be excreted into the extracellular fluid. So 420 plus 60, that is total 480 microgram in the extracellular fluid, and it will be excreted via urine. Some thyroid hormone derivatives are excreted in bile, and some of the iodine in them is reabsorbed via intrahepatic circulation, but there is net loss of iodine in the stool. It is approximately 20 microgram. Now the synthesis of thyroid hormone, it begins with the trapping of iodide by the thyroid gland. So from this picture we can see this is the step number 1, where there is trapping of iodide within the thyroid gland. And this iodine is essential for the formation of thyroid hormone. It exists in nature as a trace element. Now the iodide ion is rapidly reabsorbed or rapidly absorbed by this thyroid gland by a specialized sodium iodine co-transporter, or NIS, sodium iodide symporter or co-transporter. This helps in the process of iodine trapping. Now NIS, it is a 65 kilodalton integral membrane protein that is believed to have 12 membrane spanning segments. NIS moves iodine into the follicular cell against the electrochemical gradient of iodine. So this process requires energy. Where from this energy comes? So again in this basolateral, so this is a basolateral surface that faces the capillary of the thyroid cell, and here lies the follicle of the thyroid follicular lumen in this side, that is the apical membrane. So at the basolateral surface there will be active sodium potassium ATPase pump. It will actually utilize the energy and reduce the intracellular sodium concentration, so it will enhance the activity of sodium iodine symporter. So actually this is an example of secondary active transport. Now after entering into the cell, so what happens? This iodide leaves the follicular cells and enters the lumen of the follicle. So they will leave this cell and they will enter into the follicular lumen. This entry is also helped by a specialized protein which is known as the pendrin. This pendrin is a member of SLC26 family of anion exchanger. It is present on the apical membrane and may contribute to iodine secretion. Now it is seen that mutation of this protein can lead to a congenital syndrome known as Penrod syndrome that we will see later. Now after that, what happens when the iodide it is released into the follicular lumen, in parallel to the secretion of this, the follicular cell secretes another material, that is your thyroglobulin, into the lumen. Now thyroglobulin contains the tyrosyl group to which this iodine will ultimately attach. So first step is iodine trapping. Then this iodine will be released into the follicular lumen with the help of this pendrin protein, and there will be parallel release of the thyroglobulin into this thyroid lumen, follicular lumen. Now the secretory vesicles that contain the thyroglobulin, they also carry another enzyme. That enzyme is the thyroid peroxidase on their intravascular surfaces, vesicular surface. As the secretory vesicles, they fuse with the apical membrane. So these secretory vesicles, it contains the thyroglobulin molecule as well as the peroxidase. So when these vesicles, they fuse with the apical membrane, this enzyme faces the follicular lumen and catalyzes the oxidation. So this peroxidase now catalyzes different reactions. This peroxidase, it helps in, first is the oxidation of iodine. It also helps in the iodination, that is incorporation of iodine into the tyrosyl residue of the thyroglobulin. And one or two oxidized iodine atoms, it incorporates selectively into specific tyrosyl residues of thyroglobulin. And within the thyroglobulin molecule, so what will happen? They will undergo the coupling reaction. So we can see here, so this is the backbone of the thyroglobulin molecule. These are the tyrosine residues. So here actually, so after oxidation of iodine, so we can see this is I minus is converted to iodine. This is the oxidation process. Then they are getting incorporated into the tyrosyl residues of this thyroglobulin molecule. So when it is incorporated, iodine is incorporated into 3 positions. So that is a 3 monoiodotyrosine or MIT. When it is incorporated into 3 and 5 position, so 3,5-diiodotyrosine. So this reaction is known as the organification reaction. Now what happens after this organification reaction? There will be coupling of two tyrosines. So there will be coupling reactions. So when two DIT molecules, they will couple together, they will form the T4 or thyroxine. When the MIT and DIT, they will combine, they form the T3. Or when the DIT is present in the outer chain, so DIT and MIT combination, they will form the reverse T3. In a normal human thyroid, the average distribution of iodinated compound is 3% of MIT, 33% of DIT, 35% of T4 and 7.3% of T3. Only traces of reverse T3 and other components are present. So maximum proportion is of T4. Now as the endocytic vesicles containing, so we can see in detail of the structures again, and one important part is that these MIT, DIT, T3 and T4 all will be attached with this thyroglobulin backbone and remain stored into the colloid until and unless the TSH sends signal that it should be released into the blood. So when such signals it is there, so what happens? We can see now that the thyroid cells at their apical surface, they will extend the pseudopod extensions around small portions of the colloid to form the pinocytic vesicles. These pinocytic vesicles enter the thyroid cell. Lysosome fuse and digest the thyroglobulin in the pinocytic vesicles. Thyroxine triiodothyronine is free form are released into the cell. T3 and T4 diffuse out of the thyroid cell into surrounding capillaries, thus entering into the blood. So we now will see in details of these steps. So we know this is the thyroid follicle. So iodide has entered from this direction. Iodide and thyroglobulin, they have entered into the follicular lumen, and after the oxidation, organification and coupling reaction, they are conjugation, they have remained stored here. And we can see that every step of this trapping of iodine and then the iodination and the conjugation or coupling, it is stimulated or facilitated by the action of TSH. Now the fifth stage is the endocytosis. So this step is also stimulated by TSH. TSH stimulates the endocytosis of iodinated thyroglobulin into the follicular cells of thyroid colloid. So these are the vesicles. Now the step number 6 is proteolysis. TSH stimulates the proteolysis of iodinated thyroglobulin, forming the T4 and T3. Now these vesicles, endocytic vesicles, they will combine with the lysosome to form the lysoendosomes. TSH will stimulate the enzymes in the lysosomes. So there will be proteolysis and there will be formation of MIT, DIT, T3 and T4, and there will be secretion of T3 and T4 very near to this basolateral membrane. This T4 and T3, they will be released. Now it is seen that after that this T4 and T3 they are released near the basolateral membrane. They will readily enter into the blood and into the circulation, and the mechanism is not very much well clear. But what happens to the MIT and DIT? MIT and DIT, they are not secreted. Although T3 and T4, they are secreted into the blood, MIT and DIT, they are not secreted. These iodinated tyrosines, they are deiodinated by microsomal iodotyrosine. So they will undergo deiodination and their iodine molecule will be released, and these released iodine molecule, it will be reutilized in the further synthesis of this hormone. So the specific enzyme that is responsible for deiodination is a microsomal iodotyrosine dehydrogenase. Now in patients with congenital absence of iodotyrosine dehydrogenase, you will find that MIT-DIT is released into the circulation. They will appear in the urine as well. And it is seen that this MIT and DIT, they actually provides twice as much iodine for hormone synthesis as this sodium iodine transporter does. So we know that this iodine trapping mechanism will give supply of iodine to this cell, but this reutilization, it gives supply of twice the amount that this NIS gives. Now we know that T3 and T4, they are released into the blood. What will be the fate of these hormones now? So release and the transport of the hormone. So these normal plasma T4 and T3, they are relatively lipophilic. So when they will enter into the plasma, they will bind with some carrier proteins, and the carrier proteins are mostly, there are three types of thyroid binding proteins. One is albumin, and the transthyretin, and thyroid binding globulin. So this is thyroid binding globulin, transthyretin, and the albumin. And it is seen that out of these three proteins, albumin has the largest capacity to bind with the T4. We can see that the plasma concentration of albumin, it is largest, and thyroid hydroxin binding globulin, it is only 2 mg per deciliter. But it is seen that thyroid binding globulin has the highest affinity for T4. That's why 67% of T4, it remains bound with the thyroid binding globulin, and 46% of T3, it remains bind with the thyroid binding globulin. Now it is seen that normally 99.98% of T4 in plasma, it is protein bound, and very small amount of T4, it is free. And it is seen that this is a free form of the hormone, that is actually the physiologically it is active. And when the hormone remains in the bound form, the function of this protein binding, it appears to be the maintenance of a large pool of hormone, that is, it acts as a reservoir. That's why we can say that the T half of T3, it is much more prolonged. It is around 6 to 7 days. But in case of T3, you'll see that it is not totally, it is not protein bound as much as T4. 99.8% of T3, it is bound with the protein. So available free form is more. So that's why it is its half-life is short, and shorter than T4, and it is much more active. Now this thyroid binding globulin, their concentration may fluctuate, and we know if the concentration is increased, then the bound form will be more, free form will be less. If the concentration is decreased, then the free form will be more. Okay, so there are certain conditions where we'll find that the concentration of thyroid binding globulin will be increased. For example, estrogen therapy, heroin, major tranquilizer, or clofebrate, and in also during the time of pregnancy, oral contraceptive pill users, hepatitis, this we can see the binding protein levels, it is high. And there are certain conditions like glucocorticoid therapy, androgen therapy, and in some cancerous conditions, nephrotic syndrome, the thyroid binding concentration, protein concentration is low. But one interesting point is that in both of the cases, the clinical state, it is always euthyroid. So from why this is there, because we will see that this can be explained by this box where it is shown that the free, if we know the concentration of uh, thyroid binding protein, and if we know the concentration of total T4 or T3, we can derive the free T4 or T3 level. And if we derive it, we will see that the concentration of thyroid binding globulin, if its concentration is altered, the free T3 and T4 level, there will be negligible change into it. Now come to the metabolism. Now peripheral, we know that most of the thyroid, the hormone that is secreted by the thyroid gland is T4. And in the peripherally, it will be converted to the T3 with the help of deiodinase enzyme. So one type of deiodinase enzyme is your 5' 3' monodehydrogenase, this green arrow you can say. See, so this is 5' 3' deiodinase. So that will actually, what it will do, it will remove the iodine from the, outer benzyl ring. So from the outer benzyl ring, so here the 4 iodine is present. From the outer benzyl ring, you can see the iodine is removed. So this deiodinase, that is the 5' 3' monodehydrogenase, it will form the T3. Whereas another type of deiodinase is also present, that is 5' 3' monodehydrogenase. That will remove the iodine from the inner benzyl ring. So, and it will produce the reverse T3. So, if it is 5' 3' monodehydrogenase, then there will be production of T3. If it is 5' 3' monodehydrogenase, there will be formation of reverse T3. And these deiodinase reactions serve not only to catabolize the hormones, but also to provide a local supply specifically of T3, which is believed to be the primary mediator of the physiological effects of thyroid secretion. So peripheral conversion of T4 to T3, it is very much required, because T3 is the actual biologically active form of thyroid hormone. Now there may be fluctuation of this deiodinase enzyme. It is seen that during the fetal life, the ratio, it is reverse T3 and T3 ratio is higher. So during the fetal life, the T3 will be less and reverse T3 will be more. So after birth, this ratio shifts to the adult ratio. It appears around 6 weeks after birth. So there will be increase in T3 amount. So T3 and reverse T3 ratio will be more. Now various drugs also inhibit the deiodinase, and they will cause, if the deiodinase level is less, so this 3' 5' deiodinase level, if it is less, so there will be less amount of T3 and more amount of reverse T3. Certain drugs, they can cause this. Selenium deficiency also have the same effect. A wide variety of non-thyroidal illness can also suppress this deiodinase. So these include the burn, trauma, cirrhosis, renal failure, myocardial infarction. And it is seen that if these conditions are cured, then the T3 level will be restored. Diet also has a very clear-cut effect on conversion of T4 to T3. If there is fasted individuals, plasma T3 level will be reduced 10 to 20% within 24 hours. and by about 50% in 3 to 7 days, with a corresponding rise in the reverse T3. But the free and bound T4 levels, it remain essentially normal. So the metabolism is mainly done by deiodinase. And T4 and T3, they are deiodinated in the liver, kidney and many other tissues. Two tissues have very high T3 and T4 ratios. They are the primary pituitary and the cerebral cortex due to the expression of specific deiodinase. Now we want to see what are the different types of deiodinase are. So there are three different types of deiodinase. One is a D1, D2 and D3. All are unique in that they contain the rare amino acid selenocysteine with a selenium. So these are the selenium in place of sulfur, which is essential for their enzymatic activity. Now D1 is present in high concentration in the liver, kidneys, thyroid and pituitary. It appears primarily to be responsible for maintaining the formation of T3 from T4 in the periphery. D2 is present in the brain, pituitary and brown fat. It also contributes to the formation of T3. In the brain, it is located in the astroglia and produces a supply of T3 to the neurons. D3 is also present in the brain and in reproductive tissue. It acts only on the 5 position of T5 and T3 and is probably the main source of reverse T3 in blood and tissue. So here we can see that 80% of released thyroid hormone is a T4, and in the peripheral tissue it will be converted to T3 with the help of this enzyme D1 or with the help of the enzyme D3. D3 is a major source of the formation of reverse T3. And in brain and pituitary, the major deiodinase is the D2 and it converts the T4 to T3, and this T3 is actually responsible for the negative function of TRH and TSH and also responsible for the physiological activity of thyroid hormone. Now overall, the deiodinases appear to be responsible for maintaining differences in T3-T4 ratios in the various tissues in the body. In the brain, in particular, high levels of deiodinase activity ensure an ample supply of active T3. T4 and T3 are also conjugated in the liver to form sulfates and glucuronides. These conjugates enter the bile and pass into the intestine. The thyroid conjugates are hydrolyzed. So how actually the metabolism occurs? Okay, so thyroid hormones, they will enter into the bile and pass into the intestine. Thyroid conjugates are hydrolyzed and some are thereafter reabsorbed in the enterohepatic circulation, but other are excreted in the stool. In addition, some T4 and T3 passes directly from the circulation to the intestinal lumen. The iodide lost by these routes, it's about 4%. Now, mechanism of action. So, thyroid hormone, in general, effect of thyroid hormone is to activate the nuclear transcription of large number of genes. So, thyroid hormone receptor is located in the nucleus. We can see on the gene the thyroid hormone response element. So, this is the thyroid hormone receptor. It is also coupled with retinoid X receptor. 3 it is combining with it. Then there will be gene transcription, formation of mRNA, translation of so many proteins. These proteins are ultimately responsible for the functioning of thyroid hormone. Now, this is the function of nuclear receptor. Now, in addition to nuclear receptor, thyroid hormone may act through plasma membrane receptor, that is denoted as the non-genomic mechanism of thyroid hormone. So, this non-genomic action, it is independent on the gene transcription. Non-genomic actions include the regulation of ion channels, regulation of oxidative phosphorylation, activation of intracellular secondary messengers such as cyclic AMP or protein kinase signaling cascades. Now, the site of non-genomic thyroid hormone action appears to be plasma membrane, cytoplasm, and perhaps some cell organelles such as mitochondria in tissues like heart, pituitary and adipose tissue. So non-genomic action we expect to get in heart, pituitary and adipose tissue. Now physiological function of thyroid hormone. So these are the physiologic effects of thyroid hormone. It is seen where the functions in regard to heart, adipose tissue, muscle, bones, CNS, GI tract, metabolism, and also it has got a calorigenic action. Now we are going to all these individual actions step by step. First come to the action on the heart. We can see here the action is chronotropic and inotropic. That means thyroid hormone will increase the contractility of heart and it will also increase the heart rate. Chronotropic means increase in heart rate. Inotropic means contractility is increased. The mechanism it is that it will also do it by the permissible action of the catecholamines. So enhanced response to the circulating catecholamines and increased number of beta adrenergic receptors. In addition to that, it has its own actions. It will do all these effects by changing the cardiac output and the heart rate, and the cardiac output change via thyroid hormone will happen via two pathways. One is the direct, another is the indirect pathway. So it is seen that the large dose of thyroid hormones cause extra heat production. That leads to slight rise in body temperature and activates the heat dissipating mechanisms. These will result in the cutaneous vasodilatation and reduction in the peripheral resistance, and that will cause increased renal sodium and water absorption and expands the blood volume. So this is the indirect mechanism by which the cardiac output is increased. So this is our T3. It is increasing the thermogenesis and there will be decreased systemic vascular resistance, decreased effective arterial filling volume. So more renal sodium and water reabsorption, increased blood volume, and this will contribute to the increased cardiac output. In addition to that, cardiac output is also increased by the direct action of the hormone. So how it is doing that? We are coming later. So now this T3, one point is important. This T3 is not formed from T4 in the cardiac myocytes. This cardiac myocytes we will see in the CNS that the astrocytes, they have the ability to convert the T4 to T3. But these cardiac myocytes, they cannot convert T4 to T3. So actually these T3, what we are seeing here, it is totally the circulatory T3 that enters the myocytes, combines with its receptors, enters the nucleus, and it promotes the expression of some genes and inhibits the expression of some genes. So this T3, it will promote the activity of certain protein and inhibit the activity of certain protein. The increase in the cardiac output and contractility, its mechanism is lying into this process. So we will see that what are the proteins that are ultimately their expression and synthesis is increased by thyroid. So you will see the protein that is increased in amount is the alpha myosin heavy chain, sarcoplasmic reticulum calcium ATPase, and the beta adrenergic receptor G proteins, sodium potassium ATPase, and certain potassium channels. Their actions are enhanced, whereas some other proteins will be inhibited. For example, genes for beta myosin heavy chain, phospholamban, adenyl cyclase, then sodium calcium exchanger, and this is actually responsible for the mechanism of increased heart rate and force of contraction. How? We all know that myosins, they have two heavy chains and two light chains. These heavy chains, myosin heavy chains, can have two isoforms. One is the alpha myosin heavy chain, another is the beta myosin heavy chain. And it is seen that the myosin containing beta myosin heavy chain has less ATPase activity, whereas those having the alpha MHC, they have high contractility or more activity, and this alpha MHC is predominates in the atria in adults. Now, what is the function of thyroid hormone? We have already seen they are enhancing the activity of genes regulating this alpha myosin heavy chain. So there will be more alpha MHC and it will enhance the contractility. And alpha MHC activity level is increased by the treatment with the thyroid hormone. This increases the speed of cardiac contraction. Conversely, expression of the alpha MHC gene is depressed and that of the beta MHC gene is enhanced in hypothyroidism. So we can see that cardiac output change will be there by indirect mechanism, that is the heat dissipation, peripheral dilatation and all this. It can happen via direct action of the contractility. This is mediated by the increased concentration of alpha MHC. Now come to the action on the muscles. So the action of thyroid hormone in the muscle, we know it is catabolic. It will increase the protein breakdown. It is seen that slight increase in thyroid hormone, it usually makes the muscles react with vigor. But one point is important. Both in hyper and hypothyroidism, the muscle weakness will be seen. So it is seen that when the thyroid concentration it is very increased, becomes excessive, the muscle becomes weakened because of excess protein catabolism. Conversely, lack of thyroid hormone causes muscles to become sluggish. They relax slowly after a contraction. So both are responsible for muscle weakness. One of the most characteristic signs of hyperthyroidism is fine muscle tremor. The tremor can be observed easily by placing a sheet of paper on the extended fingers and noting the degree of vibration of the paper. Now, this tremor is believed to be caused by increased reactivity of the neuronal synapse. So, in the synapse, the thyroid hormone, it will give some excitable action. So, that is responsible for the increase these neural synapses. They control the spinal cord and the muscle tone. That's why it will result in muscle tremor. Now, the action of thyroid hormone on the central nervous system. So you'll see that we can see here the astrocyte, it is converting the T4 into T3. The action of thyroid hormone, it promotes the normal brain development. Thyroid hormone deficiency during development, it causes mental retardation, motor rigidity and deaf mutism. Thyroid hormone also exert effects on reflexes. The reaction time of stretch reflex is shortened. Reaction times means when you are giving a stimulation and when the actual muscle is contracting, this time gap is known as a reaction time. So this reaction time is shortened when there is hyperthyroidism. It is prolonged in hypothyroidism. So the measurement of the reaction time in the ankle jerk, that is Achilles reflex, it has attracted attention as a clinical test for evaluating thyroid function. But this reaction time is also affected by other diseases and thus it is not a specific assessment of thyroid activity. Now in hypothyroidism, mentation is slow and the CSF protein level is elevated. Thyroid hormones reverse these changes and large doses cause rapid mentation, irritability and restlessness. Now we are also seeing that astrocytes in the brain, they convert the T4 to T3. Now iodide presumably also contribute to deafness in Pendard syndrome that we have seen during the synthesis. So I think you remember. So there is a protein named pendrin. This pendrin protein is helping the iodide to be released into the follicular ramen, and this was the SLC26 anion exchanger protein family. And this protein, if the mutation happens, so there will be Pendard syndrome. This Spender syndrome is characterized by dysfunction of the thyroid hormone synthesis. So there will be goiter. There will be, in addition to goiter, there will be deafness due to enlarged vestibular aqueduct, due to enlarged endolymphatic sac. Sometimes the cochlea will also be affected. Now, some of the effects of thyroid hormones in the brain probably secondary to increased responsiveness of the catecholamines also, with consequent increased activation of reticular activating system. So we know that when there is hyperthyroidism, there is more irritability, restlessness, rapid mentation. We know that this is also contributed by the increased responsiveness of the catecholamines, which is stimulating the reticular activating system, which is a system of our alertness. Now, in addition, thyroid hormones have marked effects on the brain development. The parts of the central nervous system most affected are in case of hypothyroidism are the cerebral cortex and the basal ganglia. In addition, cochlea is also affected. One important point I would like to say here, because of the exhausting effect of thyroid hormone on the musculature and on the central nervous system, the hyperthyroid subject often will feel a constant tiredness. So due to this exhaustive effect of thyroid hormone on the musculature and CNS. But as the excitability is increased due to activation of reticular activating system and the synapses, the patient will be unable to sleep. So in hyperthyroidism, excessive sense of tiredness, but the patient will be unable to sleep. Conversely, extreme somnolence is characteristic of hypothyroidism, with sleep sometimes lasting 12 to 14 hours a day. Now come to the function of effect of thyroid hormone on the GI tract. In addition to increased appetite and food intake, which has been discussed in thyroid hormone, thyroid hormone increases both the rate of secretion of the digestive juices and motility of the GI tract. Hyperthyroidism therefore often results in diarrhea, whereas lack of thyroid hormone can cause constipation. Now, regarding the function of thyroid hormone in the genital tract, it is seen that this thyroid hormones is required for the normal follicular development and ovulation in female. It is required for the normal maintenance of pregnancy. It is required for normal spermatogenesis. In patients with lack of thyroid hormone, their common presentation is menorrhagia and polymenorrhea, that is excessive and frequent menstrual bleeding. Whereas in hypothyroid women, oligomenorrhea, that means reduced bleeding, it is more common. So if the patient comes with all these history, then we can also search for we can also have an investigation on the thyroid profile. Now another important function of thyroid hormone is the action of thermogenesis. So one of the principal function of thyroxine might be simply to increase the number and activity of mitochondria. It has something to do with this thermogenesis, with the increased cellular function. So there will be increased number of mitochondria, activity of mitochondria is also increased. Because we know that if the mitochondrial number is increased, so there will be more formation of ATP to energize the cellular function. And there will be also increase in the activity of the sodium potassium ATPase. So because this process uses energy, so this might be one of the mechanism which can explain that thyroid hormone is calorigenic. It increases the BMR. Thyroid hormone also causes the cell membrane of most cells to become leaky to sodium ions, which further activates the sodium pump and further increases heat production. Stimulates oxygen consumption by metabolically active tissues, and we will see that the oxygen consumption will be increased in all tissues except testis, uterus, spleen, lymph node and the anterior pituitary. This is important. So there will be increased metabolic activity everywhere except testis, uterus, spleen, anterior pituitary, and the lymph nodes. Now, another important point is that in case of animals, we have seen they have a specialized type of fat that is known as brown fat. What is the specialty of it? Uh, these brown fat, they express a mitochondrial uncoupling protein. This is UCP1. It is also known as thermogenin. So what is the function of this UCP1? It will cause the uncoupling of oxidative phosphorylation, that is dissociation of oxidative phosphorylation. So we know oxidation and phosphorylation, they are connected with each other, so they will be uncoupled. So there will be oxidation will be there, but there will be no phosphorylation and generation of ATP. Instead, that energy will be uh, used for the generation of heat. So uncoupling of oxidative phosphorylation in the mitochondria. So there will be instead of formation of ATP, there will be formation of heat. So this is a mechanism of generation of heat, and this mechanism, it is also seen in humans, especially in newborn humans. They have a large amount of brown fat, and the vital role it plays in helping to keep the newborn humans warm. Now, what is the role of thyroid hormone here? Thyroid hormone, it is seen that both T3 and as well as the beta adrenergic stimulation, they enhance the respiration in brown adipose tissue by stimulating this uncoupling mechanism. So we can say that thyroid hormones has something to do with the heat production in the brown adipose tissue too. Now, the role of thyroid hormone in the growth and development. So, as we have seen in our lectures in the growth hormone, so we have seen the thyroid hormone is responsible for the growth of the fetus, both in the fetal life and the initial few years after birth. So, initial few years after birth. After that, their level will be decreased. So, the maturation of fetus, it is very much responsible, and in the growing children, that is thyroid hormone, it promotes the development of growth of the, especially the brain of the growth of the fetus during the fetal life and for the first few years of postnatal life. Now, if the fetus does not secrete sufficient quantities of thyroid hormone, growth and maturation of the brain, both before birth and afterward, are greatly retarded. That's why congenital hypothyroidism is related with the mental retardation, and the brain remains smaller than normal. Without specific therapy within days or weeks after birth, the child without a thyroid gland will remain mentally deficient throughout the life. That's why the thyroid therapy should be started within days or weeks after birth. So thyroid is very much important for the development of brain in fetus and in case in first few postnatal years. So here we can see another picture here of the effect of thyroid hormone on the basal metabolic rate. It is a normal thyroid. In hypothyroid, the BMR is less. In the hyperthyroid, BMR is more. So it is another picture showing the effect of thyroid hormone in growth and development. The effect of thyroid hormone on the metabolic functions. In the carbohydrate metabolism, it stimulates all aspects of the carbohydrate metabolism, enhance glucose uptake, glycolysis, gluconeogenesis, increased insulin secretion. Fat metabolism, it enhances the lipid mobilization from fat tissues, increase free fatty acids, decrease cholesterol, phospholipids, triglycerides in blood. Now, vitamin requirements, it increases vitamin requirements, basal metabolic rate is increased. Now, another important function of the thyroid hormone is that it converts the beta carotene to this conversion of beta carotene to vitamin A and retinine. It is helped by the thyroxine. So it increases the absorption of B complex of vitamins, especially vitamin B12. And in case of hypothyroidism, this beta carotene will not be converted to vitamin A and retin. So there will be accumulation of carotene and there will be carotenemia. We can see the yellowish discoloration in case of hypothyroidism patient, and it is not due to jaundice, it is due to accumulation of carotene. Another important function of thyroid, it helps in the metabolism of glycosaminoglycans, and that is mostly the hyaluronic acid. Now in absence of thyroid hormone, this hyaluronic acid will be accumulated. Okay, and this accumulation is not due to excessive synthesis but decreased destruction. And this accumulation of hydrophilic substances, so they will be accumulated into the interstitial space. They are hydrophilic, so they will draw water, and what happens as a result of this, there will be interstitial edema. And what is the specialty of this edema? This edema is non-pitting edema. Okay, so in case of hypothyroidism, there will be edema, but this edema is non-pitting and it is due to accumulation of these glycosaminoglycans and the interstitial space. Now come to the regulation. So we have covered the chemistry, we have covered the synthesis and metabolism and the function and the mechanism of action of hormone. Now come to the regulation of thyroid hormone. So thyroid hormone, it synthesis, it is regulated by hypothalamo pituitary thyroid axis. From the hypothalamus, there will be release of thyrotropin releasing hormone, and it will stimulate the thyrotropes at the anterior pituitary. We know where actually these thyrotropes are located, and these thyrotropes will release the TSH. This TSH will act on the thyroid gland and it will stimulate the thyroid gland to secrete thyroxine. Now one important point is here that one of the best known stimuli for increasing the rate of TRH, that is thyrotropin releasing hormone from the hypothalamus, is seen that and also therefore TSH is exposure to cold. If the subject is exposed to cold, there will be more synthesis of TRH and as well as TSH. Various emotional reactions can also affect the output of TRH and TSH, and it is seen that when there is excitement and anxiety, so these conditions greatly stimulate the sympathetic nervous system and cause an acute decrease in secretion of TSH, perhaps because these states increase the metabolic rate and body heat and therefore exert an inverse effect on the heat control center. Now neither this emotional effect nor the effect of cold, it is observed after hypophyseal stalk has been cut. So if the hypophyseal stalk is cut, that means the connection with the hypothalamus, it is not there. So all these reactions, response to cold and excitement, it is not seen. So that means it is controlled or mediated via hypothalamus. Now, and this hypothalamo pituitary thyroid axis, it acts through the negative feedback mechanism. So when the T3 and T4 they are released, so they will give a negative feedback in the pituitary to further inhibit the release of TSH. Now what is the role of TSH in thyroid hormone synthesis? As we have seen earlier also, at every step of thyroid hormone synthesis, this TSH helps. Starting from the trapping of iodide, increased iodination of tyrosine, and increased proteolysis of the thyroglobulin, increased size and increased secretory activity of thyroid cell, increased number of thyroid cell, everything will be enhanced by this TSH. Now how this TSH it will act, we will see that this TSH, so this is the arcuate nucleus from where the TRH are released, so it will come through the hypophyseal portal circulation, it will come to the anterior pituitary and it will stimulate the thyrotropes to release the TSH, and this TSH it will bind with the G protein coupled receptor and it will enhance intracellularly, there will be enhanced secretion of protein kinase A and CAMP, and this is responsible for the functions of TSH. Now, conditions associated with hypo and hyper secretion of thyroid. So, clinical features of hypothyroidism, it is also known as myxedema. Myxedema means there will be edema, and this edema is non-pitting edema due to accumulation of glycosaminoglycan at the interstitial tissue. So, first symptom will be the fatigue and extreme somnolence with sleeping up to 12 to 14 hours a day, extreme muscular sluggishness, slowed heart rate, decreased cardiac output, decreased blood volume, sometimes increased body weight, constipation, mental sluggishness, failure of many trophic functions of the body evidenced by depressed growth of hair, scaliness of the skin, development of frog-like husky voice. In severe cases, development in edematous appearance throughout the body called myxedema. Now, causes of hyperthyroidism. It may be due to thyroid overactivity, which is seen in Graves' disease, solitary toxic adenoma, toxic multinodular goiter, early stages of Hashimoto's thyroiditis, TSH secreting pituitary tumor, mutations causing constitutive activations of TSH receptors, or it may be extrathyroidal cause, that is, if iatrogenic, if administration of T3 and T4, or ectopic thyroid tissue. Clinical feature will be high state of excitability, heat intolerance, increased sweating, mild to extreme weight loss, sometimes as much as 100 pounds, varying degrees of diarrhea, muscle weakness, nervousness or other psychic disorders, extreme fatigue but inability to sleep, tremor of the hands. So this is another feature of hyperthyroidism. There is exophthalmos, that is, we can see the sclera is visible here. Now, if we compare the symptoms of hyper and hypothyroidism, we can see that so general feature in case of hypothyroidism is hyperthyroidism is fatigue but higher state of excitability, weight loss and increased BMR, whereas in hypothyroidism, fatigue and extreme sluggishness, there will be weight gain and decreased BMR. Sleep, there will be hyperthyroidism, there will be decreased sleep, here there will be extreme somnolence. Temperature, there will be intolerance, heat intolerance in case of hyperthyroidism, cold intolerance in case of hypothyroidism. Muscle weakness in both the cases, here there will be extreme muscle sluggishness. Gastrointestinal system, there will be mild diarrhea, here there will be constipation. Increased sweating in case of hyperthyroidism, decreased sweating and scaliness of the skin in hypothyroidism. Neurological effects, fine tremor of the hands, nervousness, other psychic disorders, mental sluggishness will be in hypothyroidism. Cardiac effect, increased heart rate, increased cardiac output, decreased heart rate, decreased cardiac output will be seen in case of hypothyroidism. Menstruation, in case of hyperthyroidism, there will be oligomenorrhea, menorrhagia and polymenorrhea in case of hypothyroidism. Sexual functions, in case of men, hypothyroidism, loss of libido, in case of female, there will be decreased libido. Now, what are the investigations we can perform in for hyperthyroidism? We can do the physical examination, hormone and antibody blood test, thyroid ultrasound, fine needle aspiration biopsy, radioactive iodine uptake, and CT MRI scan. Now, regarding the management, we will see that there may be three types of management. One is a medical management, where we will, in case of hyperthyroidism, we will prevent the synthesis of thyroid hormone. So these are the medical management. Or there may be hyperthyroidism means hyperactivity of the gland. By radioactive iodine, we can destroy the gland, or if we can also do the surgery and remove the gland. Okay, so here we will concentrate more on the physiological basis of this medical treatment. There are so many drugs that is acting in the pathway of thyroid hormone synthesis. These drugs may be the thiocyanate ions, propyl thiouracil, methimazole, carbimazole, and iodides in higher concentration. So we know the steps of thyroid hormone synthesis. It may the iodine trapping, then the oxidation, then the organification, then coupling, then release. So it is seen that iodine trapping will be prevented by this thiocyanate. So inhibition of iodine trapping. Then the propyl thiouracil, it prevents the oxidation of the iodide ion. Methimazole, it prevents the organification. Carbimazole prevents the coupling, and iodides in high concentration, it prevents the release of T3 and T4 into the blood. So this is a mechanism by which they act. Another important clinical condition is the congenital hypothyroidism. So it may happen if the mother has the iodine deficiency, if there is fetal thyroid dysgenesis, inborn errors of thyroid hormone synthesis, maternal antithyroid antibodies that cross the placenta, fetal hypopituitary hypothyroidism. So this condition is known as cretinism. So the congenital hypothyroidism is a cretinism. As we know, the thyroid hormone is very much responsible for the fetal growth development and also postnatal life, the fetal brain development and brain development postnatal life. So lack of thyroxine from birth, it will cause the mental retardation. There will be stunted growth, reduced growth and functions of many other organs. So that specific condition is known as the cretinism. Thank you.